management of this abnormal placentation. So I will go briefly on the introduction. We are all focused on this new epidemic of abnormally invasive placenta, or AIP. And we still don't know yet what's the causes for that. Is it an aggressive trophoblastic invasion, or is it an incompetent decidua? And the second hypothesis seems to be the more accurate. The other speaker spoke about the identification of the patient-at-risk, and that's really a very, very important point. And especially, we all discussed about the previous C-section and the presence of placenta previa, but we have to keep in mind that the previous history of AIP, maternal age, and multigravidity are also risk factors. And so it should be really on the checklist to identify the patient at risk. How to diagnose AIP? It seems to be very important to do so because in a case of proper diagnosis antenatally, you can refer the patient to a tertiary center where a team will be available, blood supply facility, and also intervention radiology department available. So the two tools we have to do this prenatal diagnosis is obviously ultrasound and MRI. I will speak mainly on ultrasound. And the literature is very rich about the sign associated with abnormal invasive placenta. The two most important signs are the presence of lacuna. These lacuna you can see there in the middle. They generally show turbulences, and they have a very good sensibility of reaching 80%. The second sign, with a similar sensibility, is the thickness of the myometrium. If it's less than 1 millimeter associated with placenta previa, you have also a sensibility of 80%. There are two more signs which are less good, but still you have to look at them if you do a proper examination of this placenta. It is the absence of the hypogenic line between the placenta and the myometrium, and also the bulging of the placental sinus, and we use for that a color Doppler, but the interface between the myometrium and the bladder. This sign has, however, low sensibility but a very high specificity. In some cases, especially the anterior percreta placenta, we perform, as it was shown on the video, a cystoscopy. And you can see on this cystoscopy, behind the mucosa, the bulging vessel from the placenta. In that case, you should not start your C-section before putting a double G catheter to protect the ureter. So managing this abnormal invasive placenta is really a big question because the disease was until now a rare condition, but it's going to change. And all the cases are different, the family desire are different. So there is no really consensus about what to do. Do we have to be conservative or we should be aggressive? So I will discuss about the conservative management. Why? Because it's probably associated to less immediate, at least, maternal and morbidity and mortality. Less morbidity in terms of hemorrhage and extended surgery. It also allows fertility preservation, but I will discuss about what it's really the fertility for this patient. Vitamin suggests a triple P procedure if you want to plan a conservative management of this placenta. P for perioperative extraplacental hysterotomy, P for pelvic devascularization, and generally for that you use embolization, and P for placental non-separation and sometimes myometrial excision. If we check in the literature, there are a lot of reports for helping the conservative management of placenta left in situ in this case. Surgical management, embolization, obviously treatment of the hemorrhage. I will discuss about the balloon and also of methotrexate because, as it was told before, it's very controversial. In 2 years ago, I presented our unicentric study, and at that time we had 19 cases. I have to say it was the last 10 years we had these 19 cases, and since then we have 5 more cases every year. So it really showed the increased incidence of this problem. At that time, we performed only in 50% of the case a conservative management, and we are just doing for the last 2 years only conservative management. The approach is very similar to the one presented by Professor Somville. So we really plan everything if it's possible. So we have referred patients with prenatal diagnosis, and we perform systematically MRI and cystoscopy if the placenta is anterior. We plan the C-section at 37 weeks. And our last case, we did it under epidural anesthesia because we didn't have the necessity to perform emergency hysterectomy at the time being, so we do it under epidural, which is generally much more easier to manage for both the patient and the anesthetist. We also confirm that medium skin incision is compulsory. You cannot see well, and I agree that even if you have a top model, we advise them to have this medium skin incision. So what we do next, we obviously in that case the diagnosis is confirmed just by vision, but we also use the probe, ultrasound probe, to check where is the placental position in the uterus. And this is very important in the case where the placenta are not percreta and when you don't see it. After this ultrasound check, we do generally fundal or at least extraplacental hysterotomy to deliver the infant, and we left the placenta in situ. After that, we do the cord ligation, and this is an important step because we have a few cases with bleeding because we didn't ligate the cord, so it's very important to put the suture on. We use uterotonics because we have also cases with bleeding post-procedure in a twin pregnancy, and we decrease the amount of blood inside the uterus and the risk of disseminating intravascular coagulation. We do a 2-layer uterine suture, and we systematically do a post-operative embolization. We don't use a balloon pre-operatively. We prefer to do selective embolization. Obviously, the subject has been discussed. Is it better to use the balloon or the post-embolization? I think probably the selective post is better. At least it decreases the blood loss, and there is a low hysterectomy rate. But we have to keep in mind that we may have ischemic lesion and sometimes neurological sequela due to the massive embolization. If we check big series of conservative management, we have the one of Timmermans in 2007, the French series published by Saint-Hilaire in 2010, and I put my little series, but it increased, but I didn't have time to put my data. But we are more or less facing the same problem. There are failures of this conservative management, and you see that the hysterectomy is performed between 7 and 20% despite the decision of this conservative management. Embolization was not clearly explained, sorry, in the first paper. Can I go back? No, yes. We did 100%. The side effect was not really well evidenced in the French series, but clearly there is an infection rate, and we had 1/3 of the patients with that. Clearly a risk of intravascular coagulation. The French series has 1 case of maternal death, and another difficulty for us was the spontaneous placental delivery. It was very frequent in the French series, but we had to wait 3 or 4 months and we didn't have any spontaneous delivery. And so this is a concern. I will explain to you why. So, is it possible to do a conservative management if you didn't diagnose the abnormal invasive placenta? I think you saw the previous presentation that you must be cautious if you see a bulging placenta, not to decide to do a hysterectomy or classic cesarean section. And I think if you are on your own, without experienced team, you can do the fundal incision and you can do some extra suture just for the time being to keep the patient alive without too much bleeding. You can also use, and this is really life-saving, we had 1 case that managed on a weekend, an expected case, and this was really life-saving for the patient, using the balloon. And this is the series of Arduini, who present a series of 9 cases using the uterine suture and balloon, and all these cases had a good outcome. We need a follow-up, anyway, if you do conservative management, and what we do as a follow-up, we put the patient under antibiotics. This is very important for infection prevention, and we give them oxytocin for at least 2 or 3 days. We do ultrasound and ECG follow-up in the patient once a week, and we perform sometimes MRI. And you see there the placenta after a few weeks, and there was a massive invasion of the bladder, which doesn't seem to be actually present. Just a word about methotrexate. We don't use it. There is really just case report, no series, and there is a problem of safety, so we don't use methotrexate. The last point I would like to focus is what to do with this placental in situ. Do we have to remove it? When do we have to do it? And how do we have to do it? Definitely when it's just a question to see if the patient is bleeding or has an abnormal clotting test. But anyway, how you have to do it? It should be done in a very well-trained center with blood supply, because it can bleed, with also possibility of balloon embolization, having ureteric catheter, and technique may be as different as hysteroscopy or secondary hysterectomy, but definitely you have to be facing the different possibility, and it should be done in a tertiary center. I think I will be short to speak about the fertility, but I will put a word in my conclusion. So I think conservative management of abnormally invasive placenta allow a reduced maternal morbidity in terms of bleeding and in terms of visceral trauma. There is a possibility of future fertility, but it should be kept in mind that there is a necessity of careful follow-up, that there are maternal risks associated with this management in terms of infection, hemorrhage, and disseminated intravascular coagulation, and that there are risks for the future pregnancy, risk of synesia, risk of miscarriage, and there are 2 papers reporting between 20 to 30% of miscarriage, and also a high risk of recurrence of abnormal placentation. So I think we must be cautious by choosing this approach. Thank you very much.